So we'll go to the first slide, just kind of a real brief of what I'm going to go over. Okay, so a little introduction just about myself and about the where I work. Talk about the description of crisis work, how we work and what the process is of the crisis and our dispositions, and hospitalization, some of the disorders we commonly face and challenges in crisis work itself. And then we'll just kind of summarize and open up for some questions. Okay, so basically for anybody who is online or who is here, if you have a question, just go ahead and raise your hand. You don't need to necessarily wait till the end. So go ahead to the next slide. Now is the part where I get to be narcissistic, and that's my favorite personality disorder. So just a little background on who I am. I have an associate's degree in nuclear weapons technology from the Community College of the Air Force. Yes, it is as worthless as it sounds in the civilian world. I have a BA in liberal arts from Excelsior College, a very famous military college that kind of collects all of your credits and will offer you a bachelor's degree with a psychology major. And of course, I have an MA in clinical psychology or clinical counseling, as it was known when I was here 2 years ago from the Chicago School of Professional Psychology. If you're not here already, please come by because it's fantastic. Currently, I'm set in 2016 to complete my Master's of Business Administration from Southern Illinois, and that'll have a healthcare management specialization. So the reason I have a personal introduction here is because I like to always kind of give an idea of where I came from and why psychology became the field that I was interested in. I obviously don't have my several years of work history, but some of the more important ones. I work for Superior Ambulance, and for those who are here from Chicagoland area, it was a very faltering and failing company, and then, of course, as soon as I left, they got a whole windfall of money, and now it's amazing. So I went by their building a couple of weeks ago, and I'm just like, okay, that wasn't better when I was here. But I was an emergency medical technician, briefly a dispatcher, a medic, and we had a couple of incidents, which maybe we can push towards story time later. But that's kind of when I decided I didn't really want to work with the body anymore. I preferred working with the mind. So I was in the United States Air Force from 2002 to 2010 as a nuclear weapons specialist. My favorite part about being a nuclear weapons specialist is that is all I can tell you. So, and there's Dr. Spaeth, go there. How about that? Okay. So I came to Chicago School of Professional Psychology and became a teaching assistant for Dr. Dainel, who is one of the greatest psychologists that I've ever met. She's taught me so much. She's also a very, very hard taskmaster, but it was great. As far as my experience in externship, I have two. There was associates in behavioral science here in Berwyn, Illinois, where we did therapy, and we also did group work, IOP programs, what's known as intensive outpatient. And then I also worked at Holy Cross Hospital, or excuse me, not work, was an extern at Holy Cross Hospital, doing exactly what I'm doing right now down in central Illinois. I'm from Urbana right now. I'm not from Urbana. But my wife, the one who got all the brains in the relationship, is doing a PhD at University of Illinois. So essentially I did the same thing I did, and then I came to Community Elements and sort of brought my talents there. Briefly, I worked at Pro Ambulance as a dispatcher, again, down in Urbana until I was hired at Community Elements. And we work between two hospitals down there, Presence Covenant, which some of you from Chicago might have heard of Presence because their headquarters up here in Chicago, and then Carl Foundation, which is actually more of a central and southern location. So, very brief description on what is a crisis clinician and what does it take to be a crisis clinician. And a lot of people have this idea, well, until I get a grad degree, I am not going to be able to be a crisis clinician. There is what they call a crisis clinician 1, and that only requires either a BA or a BS. You do have to have a bachelor's, you can't be an associate's. And more importantly, it has to be in a behavioral science such as psych or BSW. And there's little differences in between the BS or the clinician 1 and the clinician 2, and we'll very, very briefly go over that because I want to spend more time on the process itself. Crisis clinician 2 requires an MA or an MS or potentially a PsyD, but they're sometimes a little bit hesitant to hire that because it costs a little bit more to hire someone who's a doctorate than opposed to me. As you can see, there's a big old list of what you can be in clinical psychology, counseling, MSW, LSW, and all the alphabets that make up our licenses. This is, you've probably heard this many times in your life in like career fairs, even when you were a wee one and you went to school, and somebody would come in and say, well, this job requires a very special type of person, and it does. You probably have to have an Axis Type 1 diagnosis in order to do this job. Now, it's not bad. I actually love what I do, but it is very intense, both when you're actually in the session and beforehand. So we get contracted to local hospitals. Sometimes you'll actually work within the hospital system, but usually, especially when you start getting outside of Chicago, you kind of work for several hospitals, such as Presence and Carl. And we respond to those contracted hospitals for what we call a crisis assessment and disposition. And I'll go through these a little bit more in detail, but then we'll do a DSM diagnosis and the MIMSI, which is the mini mental status exam, and then complete our disposition. So the process, and this is where I'm going to actually steal one of my sheets, because you'd think by this point in time I've actually memorized this, but I have not. But the process is you show up, and the most important thing is we try to find out the client's story. Welcome.
Hello.
Okay. So it's interesting to look at this list of things we have here, and for those of you who are not with us live, perhaps we can find a way to email you the sheet that I'm showing you. It's just a crisis cheat sheet. And basically, all these things are equally important, but the very first thing we want to know is, what is your story? Why are you here in the hospital? Because when somebody comes to us in therapy, they have things to talk about, they have things to work through, or if they go to a psychiatrist, they're in need of medical care in order to help them get through things that are troubling them. When you come to an ER, there is a reason you came to the ER. Something has happened at some point in time very recently, maybe immediately before, that has caused you to be in crisis. And that's why you're here. So we go through all these things, and the client story is the number one. But the client story doesn't just stop with what happened today. It's been what's building up to the point that brought you here. Sometimes there are people who have just build up, and the next thing you know, they can't really take it anymore. And now there they are sitting in my emergency room, and they're ready for us to potentially hospitalize them if we need to. On the other hand, and we will go over this, there are other individuals who maybe don't need hospitalization so much and just have trouble, taking care of some of the tension that they go through. I have had one college student come in who told me that she was suicidal because she lost the charger to her iPhone, and she was extremely upset. But here's the thing about that. That may sound interesting and silly in the beginning, but you have to consider, if somebody is in such a position that losing an iPhone charger is going to cause them that much grief, that's when you need to look into that history and figure out why the heck would, because I could lose my iPhone charger right now and I'd probably be pretty upset myself, but I don't think, I'd run over to UIC hospital and, talk about wanting to harm myself. So history is very, very important. We're going to kind of skip over this part because we're going to go into it a little bit deeper, but we're looking for the intent to harm themselves or others, or the inability to care for themselves, also psychosis and delusion. The current mental status. That's very important as well. We'll discuss that in a moment. Past use of services, including hospitalization, medical history, living situation, substance abuse, all these very important to go through. Okay, so as I don't know if anybody here has done a mini mental status exam yet, but it covers a lot of different things, and it really wants to give you an idea of the person that's sitting in front of you. Where is their mindset right now? And it always starts with what we call the alertness and orientation scale. Now, when I was on the ambulance, there used to be 1, 2, and 3, but this part number 4 didn't exist. Now, I'm not trying to say I'm old, because if I did, Dr. Spaeth would probably come through the screen and yell at me. But the point is, I like it to say back in my day now, but it used to be, just the 1, 2, and 3. So the purpose of that is to find out, do they know who they are? Do they know where they are? And do they know what time or day it is? We try not to trip them up on purpose. Can you tell me what day it is, sir? Can you tell me the exact time to the second? Oh, you're wrong. I'm sorry. You're going upstairs. But they've added, over the past couple of years, this fourth piece called situation. And this is actually a pretty important one, because it may be very easy for me, if I'm in a crisis situation, to say, okay, I know I'm at UIC hospital. I think it's Friday. I know my name. But do you really know why you're there? That's an important piece. So that kind of drove why they add that, why they add that fourth piece, even to the medical field and, ambulances and whatnot. And we look for things such as thought content and reality testing, and that's where the idea of psychosis comes in and delusion. Are these individuals who are what we call returning to external stimuli or internal stimuli? And right now, people who are watching this, I hope, are responding to external stimuli. You see me talking, you're writing things down, you may be formulating questions, maybe thinking, for the love of God, I hope this ends soon. Or is it internal stimuli? And internal stimuli, it can sometimes be really subtle, or it can be really bold and blatant. It could be simply somebody, you can see somebody kind of closing their eyes, clenching their fists, and trying to figure out what's going on up here, and there becomes almost like an affect to it. You can see inside of them that they're responding to something that is not there for you to see. Or it can be bold and blatant. 2 weeks ago, I had a woman who every time I asked her a question, let's see how can I do this, you'll have to pretend that this is a wall. So she's laying on the ground, I would ask a question, so she'd be looking right at me, and then she'd go, excuse me. And she would proceed to look at the wall and ask somebody that was in the wall, am I allowed to answer this person's question? That's internal stimuli. Sometimes it could be faking, we'll get into that later. But the point is, that's what internal stimuli is. These are people who are in such a psychotic or delusional state that they are looking, not beyond what's going on in their own processes. Hallucination, we have several different types of hallucinations. You'll usually hear auditory. Auditory, visual, which means eyes and ears. They also have an important one that a lot of people don't recognize so much called command hallucination. And command hallucination is now somebody or something inside their internal process is telling you to do something. Hurt yourself, hurt somebody else, Or in my case, I had a gentleman who tore out his plumbing because he said his plumbing was racist because the voices inside said the plumbing fixtures were white and he was black. So he had to tear those out because that was part of the government conspiracy to, I think he said it was end his life or something like that. So we look at sort of things. Speech rate and clarity. Can anybody guess why this would be important? A DSM diagnosis we might be looking at for this?
Mania.
Mania, exactly. If I get a 5-hour energy or two in me, I could produce some mania for you, but maybe I'm doing it a little bit hypo right now. But mania, very fast and what we call pressured speech. This is a person, and I mean, almost all of us, whether you suffer from bipolar or not, have gone through manic speech before, where you have all these thoughts that are racing so fast in your head that when you try to put them out, be it on paper or verbally, it's going to spill out, and you can't control. So as you're getting one thought out, the next thought is already pressing behind it, and you kind of have this manic rush, oh my God, I can't really get all these feelings out type of speech. Mood and affect. So we kind of look at these, and I also have level of cooperation here because that's kind of important. We're going to see, how cooperative they are. But mood and affect, are they euphonic, which means you're feeling good, life is fine, or am I dysphoric, or I'm feeling just kind of sad, down, malaise. But then we also have the affect with it because it's very important to see if these things match. To be congruent means that your affect matches your mood. So right now I am euphonic. Life is good, I'm doing fine. And my affect matches that. I am congruent because I'm up here, I'm doing pretty well. But if I was talking all happy, but the entire time I was crying up here, that would be is it discongruent? Incongruent? Incongruent, okay. So we have to look at, what matches. And then we also have a very important one called flat or blunted affect. This is often for somebody who is in a position where, and when you see somebody for the first time in flat affect, you will not forget it because there is literally just nothing here. I mean, I'm a very lively, sometimes labile individual, and I have, but when you see these people, there is just nothing in the eyes, there's nothing in the face, it's just sort of apathy. And then of course you have other ones like labile, expansive, and expansive goes along with mania, where their world is this big compared to yours, which is right about there. Memory, we have usually in the crisis situation 3 types of memory: immediate, short, and long. For those of you who have gone through any sort of cognitive courses or courses that do the mini mental status exam, you'll learn ways to test those types of memory. Hygiene and grooming can be kind of touchy because perhaps this person is homeless and maybe they haven't had a shower in a while, or perhaps the person is so depressed they haven't showered in a week. These are things that kind of help you build a story. Your attention, psychomotor agitation, or psychomotor, what they call retardation, where everything is just sort of slow. Okay. So these are, I'm going to really speed through these because it's not as important, but these are some of the emergency procedures. These can only be done by medical staff. We are not allowed to, we can request these things, but we cannot administer or suggest that this is what needs to be done right now. Restraint procedures, 4 and 5 point, which means somebody's laying down. That means each arm and each ankle is tied down. However, if you have somebody that is violent enough and you think they're going to hurt themselves, they also have a chest band that can go across. If they're in a wheelchair, they can also likewise be restrained down in the wheelchair. Do you have a question? Or?
Oh, no.
Okay, I'm sorry. Chemical restraint, I don't know if anybody's gone for psychopharmacology yet, but you may recognize some of these, and now I'm going to focus on this because this is a mistake. It should say SL for sublingual, but not a big deal. Typical, you'll use Haldol or Ativan, and you'll see here that can only be ordered by a top-tier medical staff like an MD or a PA. Haldol and Ativan, oftentimes called the B52 because they'll give 5 of Haldol and 2 of Ativan injected to help somebody who's psychotic or manic come down. Very rarely used is Zyprexa. It's a sublingual tablet, which means it goes under the tongue and dissolves for more minor psychosis. Giers is sometimes used, again, as an injectable for mania psychosis. And then this bottom one, which I've only seen used one time, and it works extremely well. It's called ketamine, and it's meant for full-on sedation, which means these have not done a darn thing for you. And when they hit somebody with ketamine, I mean, that's it. I don't care how big you are or how bad things are going, you're done. So much so that it is an Illinois requirement that you actually have to monitor the airway and circulation because it can stop your lungs from functioning. Okay. Okay. Now, here's the part where I'm going to go back and forth between speeding up and slowing down. I'm going to ask you first to focus on these first 3 dispositions. Depending on the hospital system you work in, you have a tendency towards one of 2 things, the high end or the low end. The high end, being hospitalization, means that you feel that somebody needs to be psychiatrically admitted, meaning they're going to go to a hospital, they're going to be seeing a psychiatrist, therapy groups, and I mean, I'm sure most of us know what a psychiatric admission is. The low end, or the least restrictive, is discharge, which means you're going to release them. And you always, always, always have to have a safety plan in place and follow-up instructions. It is not going to be beneficial for someone to walk out of your ER and say, good luck, I hope things get better, because you're not instilling that hope. And for those of you who are students who have heard it 1,000 times in here, you've got to instill hope for people. So you'll see kind of the second one says step down. This is only in a few places, and it's not really everywhere, but it's a nice thing to have. A step down is midway between hospitalizing somebody and discharging. It's usually a voluntary program, which means it's like a psychiatric admission, but if they want to go outside, get some fresh air, or maybe they need to go down to the corner store, get a drink, not an alcoholic drink, mind you, but like a soda or something like that, they have those capabilities. But you have to consider elopement hazard. Elopement means somebody's propensity to run. I'll kind of come back to this in a second, but then they have medical admission. This is a humongous pain in the rear because I cannot tell you how many times I have gone through 2 hours of work trying to hospitalize somebody for the MD to come back and say, you know, we found some really abnormal heart rhythm, let's put them upstairs. You're like, thanks for wasting my time, have a good day. Again, only decided by medical staff. Residential substance treatment and detox. A little bit of difference. Detox means you are literally withdrawing right now from your drug or alcohol of choice. It is much more of an emergency situation, meaning you need to see somebody right now who specializes in taking care of somebody coming down, whereas residential can be like a 30, 60, 90-day treatment. Always voluntary. You can't make people go to these unless it's court ordered, but that's not our decision. And then nursing home, you know, if we have somebody who does have a severe cognitive delay, such as Alzheimer's or Parkinson's, you know, perhaps Huntington's, which is a bit more rare, these are individuals who maybe need to look into, and you have to consider the power of attorney because they often have them. State hospitalization, you'll see McFarland up here. Some of you from the the northern Illinois part might recognize Madden, Weed, and Elgin. These two you probably never heard of. Alton and Choate, these are all southern Illinois and western Illinois. State hospitalization is made for somebody who has been in the hospital so many times and have either an absolute refusal to continue with their medications or they are just not functioning at all. This is severe. You go to a hospitalization, you could be there anywhere from 3 days to 2 weeks. McFarland, the typical minimum is usually 1.5 to 2 months, which means they are on that unit for that whole time. So this is the slide that I really like going over. These are the reasons you should hospitalize somebody. At all times, I didn't write these down here, but you should see the word imminent. Imminent is one of the most important things. Now, I could come to you and tell you that I felt suicidal for several months, and that is something that you have to be concerned about. You know, you have to think to yourself, okay, well, this person has obviously got something going on. But the imminent danger, is it there? Is the imminent danger there? Which means, imminent means immediate. Immediately now, immediately in the future means if I were to let this person go, is he going to walk out in the street and try to end his life right now? If that is what comes across in your assessment, this is a person that needs to be hospitalized. Okay? Suicidal, homicidal, acute psychosis, and inability to care for yourself. These are generally the 4 reasons you can hospitalize somebody. Again, suicidal, imminent danger, you have to look for their plans, their means, and more important, sometimes more importantly, their history. Because some people will desperately need to be hospitalized, but they will lie to you and tell you, no, I'm totally fine. But then you come to find out later through calling your family members, oh, he's tried to kill himself 10 times through ODing. Okay, this person has history. Plan and means that they've got a plan in place saying, I would like to go out and do such and such. And a plan can either be vague or it can be very distinct. Now, I've had a person who came in, and we'll talk about gesture and attempt in a moment, but I've had a person who said, oh, I think I'd like to run into traffic. Okay, that's concerning. But if somebody goes, I would really like to go out and shoot myself, I have a 9mm Glock at home, okay, well, this person's actually thought of this. You can tell there's some detail orientation here. Then there's a gesture versus an attempt. And we all have heard, you know, the things such as an attempt. We all know the famous saying that women will attempt suicide more, but guys will be more successful, which I think is a terrible thing to say, successful, because regardless. And we all know that, you know, for those who have studied know that the reason is that guys usually choose more deadly methods, more fatal methods, such as a gun. Gesture versus attempt. I'm sorry, I'm a storyteller sometimes. I had a gentleman who came in from a prison who had literally broken 3 vertebrae in his neck because he tried to hang himself and nobody found him. They had to do CPR on him for a half an hour. That's an attempt. The gentleman that shot himself, that's an attempt. A gesture, on the other hand, we have people who, I had a person who came in who took 2, I promise you I'm not lying or exaggerating, 2 vitamins saying he wanted to kill himself. A vitamin, okay. The worst thing that's going to happen is he's going to have a lot of B vitamins going out in his urine. But the point is you still have to take it seriously and consider it. If he felt like he was going to kill himself by doing it, then there's something there. Homicidal you don't run into nearly as much. Suicidal and psychosis are the ones you run into all the time. But homicidal, again, immediate danger, imminent danger. Look for the plan, the means, the threat, and the target. And then if you have all of these in place and somebody wants to do something, then you have to do what you call an intent to harm notification. This is mandatory. You cannot skip this part or else you can be held liable. An intent to harm notification involves the police and the target. Literally about 4 weeks ago, I just did my very first one. And I'll give you guys a second if you want to maybe back off and not hear this story. But we had a gentleman show up. Okay, giving everybody a moment to take off if they don't want to hear us. We had a gentleman show up who said that he wanted to kill his girlfriend. He was also suicidal. And I asked him, well, because I've heard people say, I want to hit somebody, I want to kill somebody, and not that I don't take it seriously, but the plan and the specificity isn't there. And I said, do you have a plan of how you would do it? And he said, yes. And I said, what would you do? And with this complete deadpan lack of expression, he said he wanted to push his girlfriend up against the wall and then stab her in the heart very slowly with a knife until he could see the life blink out of her eyes. Now, that is a much more serious and much more imminent concern than me saying, oh, I really feel sometimes like I want to hit my girlfriend or something. Neither one is good, but you got to consider. So we did an intent to harm. And actually, one of my colleagues who took over the call in the morning, I only got the police portion of it done because it was 3 a.m. and the girlfriend hadn't answered, and she was taken back by this. She was like, I can't believe that he would say these things. Acute psychosis. This is where things get interesting. We look for generally 2 different things, delusion and hallucination. Delusion can come out with delusions of grandeur, bizarre thought, paranoid ideation, sometimes manic behavior when you're looking at something like schizoaffective disorder or bipolar with psychotic features. These are things that we have to watch out for. Is this abnormal? But more importantly, is this different from their baseline? Somebody who suffers schizophrenia, this may be their baseline behavior. Doesn't mean it's a good thing. But we are concerned with, does this person need to be in a hospital right now? Okay, and then of course hallucination. And I put a big old list here with the command tactile, touch, and olfactory. Frankly, these first three are the only ones I've ever heard. I've never seen somebody come in with tactile or olfactory. And I just realized that tactile and touch are the same thing, so we'll carry on. If I could have, for inability to self-care, this entire area would be asterisk because this is very important. You have to have an extreme extent for inability to self-care. Now, when I say extreme, it means that this person has not cared for themselves so long and they're so unable to care for themselves for so long that they are literally not functioning. You know, it could be catatonia, where they're literally just out and there's nothing to them, or it could be somebody who has not eaten in 2 weeks and say something like their potassium or sodium level is so low that it presents a danger, or something like their heart system, you know, their lungs and such. The reason I put this thing down here that says extent must be extreme is a lot of family members will bring in their, you know, family members and they will say, well, my son hasn't eaten for 2 days. Okay, that's not good. But is he capable of eating? Well, yeah, he could eat. He's just depressed. Okay, well, that changes the game completely. Now we're no longer looking at this. Now we want to look at depression and suicide. But somebody who doesn't want to eat, you know, or somebody who overeats for a couple of days, or maybe doesn't bathe for a week, that is not an inability to care for herself. Likewise, and this is not meant to be an offensive term, but somebody in a wheelchair who has the inability to care for themselves on alone is not an inability to care for self. This is somebody who's either so psychotic or so suicidal that they have literally just lost any ability to take care of themselves for a lengthy period of time. The reason it's so important is that the state's attorney for your location is going to have a very hard time selling this, you know, to the district and to the courts. Okay. Types of admissions. Don't worry, this will be a little bit of a quicker one. You have voluntary, involuntary, and medical. So now we are moved beyond discharging, and we have realized that this individual needs to be in a hospital today. We'll go down to the bottom one first, medical. Admitted for medical reasons, found during the assessment prior to or after, and again, must be determined by a medical staff and accepted by what they call a hospitalist. That's the person who's actually going to take care of them medically while they're on the floor. Voluntary is the easy part, and we always prefer to be voluntary. Client is agreeing to be voluntarily hospitalized, which means that you've talked to them, they've realized that they're having a lot of troubles, and they're saying, yes, I'm willing to sign a form to say that I'm going to a psychiatric facility. They need to understand what they're signing, otherwise that can get you in a little bit of trouble. The voluntary sign usually has to be signed after admission is accepted. So presence, we have something we call 5 East, and that's our psychiatric floor. Presence will call and they'll go through the process and say, okay, we're going to accept your client, and then you go into a voluntary form, and then everything's good. But then we come to the problem of involuntary, and this is sometimes where things can get very ugly. You are literally removing the client's rights, and you know, they are no longer in charge of their decisions. So you are saying that this person is in such a danger, and you believe that they are going to make irrational and dangerous decisions that, legally speaking, I'm taking your rights away. And that's it. Once you do that, it's over. So they have to pose an imminent danger to themselves or others, or again, inability to adequately care for themselves. We'll go over that in a second. Okay, so I could spend literally a day talking to you about these 3 forms, but we are going to whip through them very quickly. Okay, so we have these pulled up, but I'll just go very briefly. The petition is something that can be filled out by anybody that's an adult. Technically speaking, if your mom is still with you, she could petition you to a hospital right now. That's kind of a scary thought because I don't know why my mom hasn't done it to me yet. And it cannot be filled out on or by a minor. I found that out the hard way. Anybody who is not emancipated and is a minor, as per the state of Illinois, they cannot have a involve done for them. Certificate must be hand-filled by the doctor. They will tell you all the time, hey, can you just type this up and then I'll sign it? No, that's bad. Time and certificate is a little thing that you just have to know is that if you're going to do both of these, which they both have to be there, the time and certificate has to be after that. USARF is for admission to a state facility, or in some cases used for SAS and Medicaid, like in areas of Chicago. So we're going to pull up the petition first, and that will be, should be the first one. Yep. Okay. So again, I could go for days on this, but we're just going to go through and give you a brief idea of what it is. Okay. You can always look up online, you know, like what the judicial court is and the county, like this would be Cook County. I don't know what the court name is, but for us down south, it's 6th Judicial in Champaign County. Name, you would put involuntary because we cannot make judicial decisions. And then this right here is the location saying where they are. So right now they're at Holy Cross Hospital Emergency Room or Presence Covenant Emergency Room. We have to make sure this is checked. We are not really concerned about the rest of these. So we're going on to page 2. Okay. So again, you put your name up here. I assert that name is all that applies. This, the fifth box always has to be checked because you are saying that the reason you're doing this is the person is in immediate need of hospitalization. Okay? Then you have to decide what's at play here. You've got all these reasons, like this bottom one is developmental delay and they can't, or developmental delay and they can't really take care of themselves, or a person who is of mental illness and they can't really make decisions for themselves, they're going to harm themselves, they're going to harm someone else. You know, so you have to check these boxes, and you can usually check 1 or 2, but whatever you check on here had better be on the certificate as well. Down here is your narrative. I cannot even begin to tell you how important the narrative is. It has got to be strong. And when I say strong, you better have very good reasons why you're taking this person's right away. And this isn't to scare people away from involuntarily admitting somebody. It's just saying that I can't just put in here, you know, patient is psychotic, he's delusional. Why? What do you see? What's your proof? Patient is psychotic. Patient tried to, you know, stab roommate. When I had a guy show up to his roommate's door with a full-on samurai sword asking if he was going to kill him, you know, that kind of thing, okay? Details. Got to have details. These are witnesses. Your name is always going to be here. Anybody witnessed it. This is generally an area like you put a family member that you at least told them, you know, hey, this is what's going on. You know, you really tried hard, but if you can't do it, you can always say, hey, I tried these steps. These should always be I do not because these are legal or financial interests, in which case if you have a legal or financial or personal interest in a patient, you shouldn't be seeing them anyway. We don't worry about that box. Just should always say 1 certificate of examination is attached. This box right here is just saying whether or not a police officer took custody of the person and brought them to the ER. If they, you know, the police showed up and then sent them by ambulance, then we're just going to hit no and move on. Okay. Just put I do not wish, because otherwise you're going to get a humongous amount of paperwork saying, guess what, your patient was accepted or rejected. I mean, if you really want to, that's fine. Sign and date, and that's a petition. This part is just the portion that will sign and date again and give to the client so they know what their responsibilities are. So we're going to go on to the certificate. Okay, much shorter form, but just as important. If you would like, and if your doctor is lazy, I apologize for any doctors watching this. If your doctor is not wanting to do it, you can do things like fill out the name. You can put the date again, make sure that the time is after the petition. You can fill out the name again, but beyond this, they've got to do the rest themselves. There's the boxes I talked about. They need to match, and they need to say in need of immediate hospitalization. I don't like that this has an area that you can type in because you're not supposed to do it. Even the doctor himself, if he's putting his own thoughts, is not supposed to type this in. It needs to be handwritten. So this will be their area to write down. You'll find sometimes that doctors can be very vague, you know, like I was talking about, oh, a person is psychotic and delusional. That's where you need to step up your game and, you know, kind of be bold and say, you know, doc, I need you to really be detailed here. And then they'll fill out the rest. So I am literally just going to show you the USAR form because this thing is a pain in the rear and it takes a long time to do. Again, SAS does these all the time. I don't know if anybody knows what SAS is, but they're what we do, but for kids that are 20 years and younger that are on Medicaid. So that's what SAS is. But basically, the uniform screening and uniform screening. Let's try this again. Uniform screening and referral form. If you're going to send someone, you know, that's somebody that's SAS, or you want to send them to a state facility, I mean, if you want to scroll down just a little bit, you know, there is so many things that you put in there. It's almost like you're doing your history again, but even longer. There's so much stuff on there. They have this, like the alcohol ones, the last time they used, how often do they use, physical situations, personal history, assets and strengths. I always have a hard time with that one, but, and here's your MIMSI right here. So that you get the idea. You know, this is, I mean, it's a very lengthy procedure, but it's very important for state hospitals. Okay. And we'll go to slide 13, and we're getting close. I'm actually timing this pretty well, so I'm pretty happy. Okay, what do we usually run into in a crisis situation? I kind of sort of had these in order, but not really. But most importantly are these top two, mood disorders and thought disorders. This is the bread and butter of what you're going to see inside of a hospital emergency room. And it'd be really hard to say, well, okay, I see mood disorders more than I see thought disorders, because it really, it kind of depends. Oftentimes during the summer, the weather gets, a little bit hotter, and things like psychosis and delusion will come out a lot more. Then in the wintertime, somebody who might be schizophrenic might be, holed up in their house, whereas some of the mood disorders come out. Seasons are changing, and holidays are coming up. But in reality, kind of a fun fact is holidays actually have no bearing whatsoever on suicidality or attempts or ideation. It actually sometimes tends to lessen them, because those might be the 1 or 2 occasions where you'll actually get to see family members. So mood disorders. The 2 most important ones, bipolar and major depressive disorder. You'll see a lot of major depressive disorder, but actually you'll usually see bipolar more often. And they will either come in a manic state, or they will come in a very depressed state, because what you need to understand sometimes is that when you're depressed, you have your baseline, okay? But then you're having a depressed episode, and now you're down here, and things are not looking good. Things are, painful. Things aren't going well. But consider the drop that it takes from here to here, and the drop it takes from when you're manic and life is euphoric and you're happy, and then you come all the way down here. Or you might have somebody come in a manic state who is so manic that they don't really know what's going on. They can't function. But that is actually a reason to hospitalize somebody if it's severe enough, because these are people that can go out on unrestricted drug sprees, or end up walking in traffic because they're threat seeking. So you'll see bipolar and major depressive a lot, and again, you're looking for suicidality, sometimes homicidality, but then you come to the thought disorders. And this is where things get a little bit dicey from time to time. Schizophrenia, schizoaffective, or typically what we'll diagnose as psychotic NOS. These are people that are coming in who are extremely paranoid, or having a lot of abnormal, bizarre behavior, and these are things that we have to consider and look out for. Adjustment disorder. I actually put an asterisk on this one. When you're in crisis work, you have to have an Axis 1 disorder in order, regardless of what you're going to do, whether you discharge or hospitalize, or in our case, when you step down. We can't just say somebody has borderline personality disorder, which you will run into a lot in the hospital. But they have to have an Axis 1 disorder. So this is our kind of cleanup disorder. An adjustment disorder basically means that somebody's had some sort of life circumstances that they haven't adjusted to. And I mean, there's like mixed type, anxious type, depressed type, so you can look into that. Then the personality disorders. Borderline and antisocial are the ones that I have highlighted here. First of all, because as I understand it, DSM-5 has erased half of them. But regardless, borderline personality disorder is the one you're going to see the most. They're looking for attention. Now, this is not to say that this is always the case, but people who are borderline, which I see many, literally sometimes 3 times a day, they will go to the hospital for weeks straight, over and over and over again. You know that they're attention seeking. You know that this is how things are working, and this is their MO. A little less, or a little more rare, is antisocial personality disorder. Somebody who might have a bit of a criminal history. Somebody who might want to harm somebody. So these are things to consider. Is borderline a reason to put someone in the hospital? Not really. Have they done something to themselves that is actually dangerous and life-threatening? Then yes, that would be a reason. The anxiety spectrum usually kind of comes with typically like a mood disorder, PTSD, post-traumatic stress disorder. You don't really see acute stress disorder, because by the time they've seen you, something may have been going on for years, such as sexual assault, molestation, that sort of thing. GAD, generalized anxiety disorder, or panic disorder. You kind of see these attached. Occasionally, you'll see somebody come in who's having a panic attack, but a panic attack it's serious, it's rough, but we can't put someone in the hospital for that. And then substance use related disorder, which we'll go over in a second. Okay, the challenges faced during hospitalization. So we're not talking discharge now. We're talking we want to put someone in the hospital, or somebody wants to be put in the hospital, and we know darn sure that they don't need to be there. Number 1, V65.2, malingering. Does anybody know what malingering means? Of the 2 folks that I have here, or maybe anybody on, okay?
Faking bad to like to get another secondary gains?
Absolutely. Malingering is all about things are necessarily not going bad, but we're going to push them to get, to sound a lot worse than they are, or make something up. There is a gentleman who I won't say his name because he will literally manifest, and he will show up here at my hospital and say, I'd like to be hospitalized. So there's a few of them, who malingers so poorly that he will literally go in the hospital every single night and say that he wants to stab himself in the stomach. We know full well it isn't true. He's never tried to harm himself before, but he will push. Because if we let him, he would literally live on a psychiatric floor for the rest of his life. Because they he wants the attention. Or, in the other case, he just wants someone to take care of him. Manipulation kind of goes along with malingering. Now, you'll see that I have homelessness up here. Now, I am very, considerate, towards homeless, but once winter comes, we see a massive incline in the amount of homeless people who will say that they're suicidal in order to come to our step-down facility. Because, and you've got to understand, too, if I were homeless and it were negative 10 degrees out, I'd probably do everything I damn well could in order to get somewhere that's going to be warm and there's going to be food. In Champaign County, we have a pretty rough and almost non-existent homeless resources. We do have two. One of them, if you have any felony on your record, you can't get in. The other one is a great facility, but it's very full. They can handle a lot of people, but when you consider taking 50 to 100 people off the street and there are 1,000 homeless people, that kind of gets rough. However, in Champaign County, we do not have a women's homeless shelter. The nearest one is about 45 minutes away. There are a very few for women who have children who have literally just come out of abusive situations. And I can see the look that you have on your face, and it is terrible. It is very terrible to have women come in, and I'm saying, I'm sorry, we can try to get you to Bloomington, we can try to get you to Cater, and that's, the bus tickets aren't that expensive, but the fact of the matter is the resources aren't there for them. So, good. 15.81, noncompliance. Oh, we run into this a lot. You'll actually run into this many, many times with two disorders, bipolar with mania, and also psychotic disorders. Because these are people who will often take their medications, but then they'll realize, well, damn, I feel better. Life is good. I guess I don't need these anymore. Now they were just medicated, and they dropped even further, so they're going to pop back in your ER. Now, the problem is, anytime you go to hospitalize somebody, you have to have a doctor's agreement. So you're presenting this situation. I would like to hospitalize so-and-so. And then the nurse is going to tell the doctor, and the doctor is going to be like, okay, we'll accept. Or they may have people that they know have literally a long, 10-year history of noncompliance. And as sad as it is, you've got somebody who's in such crisis, but what can you do? He's just going to keep taking beds for somebody that could really use the help and that wants to, make the move. So noncompliance becomes a real problem and bogs up our system. 61.21, abuse and neglect of a child. Notice this says mandatory. Just like intent to harm, if you do not make this call, you can get in a lot of trouble for that. DCFS, even if you can't just say like, oh, this person's not a good parent, it's called DCFS, but if you have reason to believe that somebody has harmed your children, or if you have a child and you believe they're being harmed, you better darn sure be on that phone making that call, because it is extremely important, not just for your, not just for your own personal good, but consider a child. You want to get that child out of the situation. I'll kind of level out the stories now, but I had a woman who was brought in for anger issues, and it was found out that she took a 40-pound bag of dog food and knocked her 6-year-old child off her chair and ended up injuring her. So I did a DCFS report. It came back, my first found it ever, where all 4 kids, I think had something like a 10-year history of being abused, and they pulled them all. So it's important. Like I said, not just for legal issues. Okay. BIFs, anybody know what BIF is? Borderline intellectual functioning. So you've got MR and DD, which is like mental retardation and developmental delay, and then you have borderline intellectual function, which means it's a little bit low, but not to a severe enough degree. You have to consider as well, is this decreased functioning, baseline, or is this somebody who's got DD but who is legitimately suicidal? One of my colleagues actually had someone who had a legit case of Munchausen syndrome by proxy because his mom was trying to get him hospitalized, and that turned into a whole story. But he's not here, so I'll have to leave that to him. And then you have dementia. This is a real problem for crisis workers because family members have a very difficult time realizing that dementia, while it is serious and it is very sad to see someone go through, it doesn't mean that this is somebody that needs to be hospitalized. No, medical hospitalization? Yeah, possibly. But this is somebody who might, want to look into a nursing home or assisted living. Psychosis and mood related to substance use. Anybody know what spice is? Spice is synthetic marijuana. Spice is relatively new, but it's new in the fact that it's becoming more and more used. Now, people have used marijuana And it can mess with your memory, it can make you hungry, those sort of things. And, it can make you forgetful and, have some cognitive issues. But spice is really bad. Spice is something that cannot be tested for in drug tests right now. They do not have any ability to do so. And it will make somebody unbelievably psychotic, to the point where they are throwing things, hitting people, they have no idea what's going on, and it is very dangerous, and it is becoming, unfortunately, the wave of the future, because they know full well that I could go out and smoke spice, and if I happen to get through the day and not end up, harming myself, I can go into work the next day, be tested, and they're not going to find me. But it is extremely dangerous because, not that, marijuana has regulations in it, but there's been years and years to cultivate this, whereas spice is just to get the job done. And then involuntary admission with open criminal history. This is a weird one. If I have somebody who needs to be involuntarily admitted and they refuse to go to the hospital, and they have an open felony or an open misdemeanor, I cannot hospitalize them. I know that sounds really bad, but it is unfortunately the case because criminal history always supersedes civil law. When you hospitalize somebody, you're going into civil law, but if they've got open criminal history, can't do it. I'll go to the last slide here. So the challenges faced by the crisis staff. And each one of these are just as much a pain in the rear. Medical staff lack of specialization, not that they don't know things, but let's be honest, we are all here because we are studying mental health. We have made this our life's journey, so it's very hard to get people to get on this medical model and say that, well, is this really a crisis or is it really not? However, this is the hardest part you'll ever have to deal with in emergency health care is family and friends. They will advocate, and that's very important to have someone to advocate, but they will become so over-emotional sometimes that they don't realize that while this person did cut themselves with a butter knife and made a very, shallow cut, while that is important to to work with, that's not a reason to put someone in the hospital. But they'll continue to push and push and push, for hospitalization. And they can also go through secondary trauma. When you live somebody, who's been through psychosis for so long and you've watched this happen, it's going to weigh on you. And I'll pop down here and say the same thing is, if you are in this school or any school that talks about psychology or social work, you've probably heard about self-care. Please do your self-care. That doesn't mean going home and drinking. It means go do something to help yourself. Because I don't care if you're a therapist, I don't care if you're a tester, I don't care if you do emergency work, whatever you do, if it's in medical health care or mental health, regardless of what it is, it's going to get to you someday. I'm not saying that 2 years from now you're going to be a blubbering fool laying on the ground and you can't function, but this stuff is going to come home with you sometimes. You've got to understand that. So take care of yourself. And then law enforcement. I can go for days complaining about that too. They sometimes write, I don't know if there's any police on, so I apologize. They write some of the weakest petitions I've ever seen. Sometimes they don't sign them, and then they're just completely, there's no reason to have them there anymore. And sometimes they'll want every single person that's, has cried once in their life to be admitted, But you got to understand, too, that they don't really understand mental health as well as we do. I think that is our conclusion and time for a few minutes of questions if you have any. But I left this Bill Clinton quote up here. It says, mental illness is nothing to be ashamed of, but the stigma shames us all, and that is exactly the purpose. What it all comes down to, whether you do therapy, whether you do crisis work, whether you work in medical, it doesn't matter what it is. Being mentally ill is nothing to be ashamed of. But we live in a society, unfortunately, that looks at mental illness like a weakness. So if anybody has any questions, I'll be more than happy to answer them at the moment. Otherwise, we can wrap up.
I have a lot of questions.
We'll go ahead and throw a couple at us. We got a few minutes.
So one thing you mentioned was the faking.
Mm-hmm.
How do you know someone's faking?
Oh, I wish Monica was here right now. Monica's my supervisor. We have some people that are faking. Unfortunately, sometimes it becomes a history. You have to have a history of this individual. But then again, you also have to look at the story. Remember I said you got to build up a history. Now, I've had people who have told me, I want to go out and cut myself. Okay, well, where do you want to cut yourself? You get these details because, unfortunately, unless they're a super genius, people who manipulate are going to mess up somewhere. They're going to screw their story up somewhere. We have a person, again, I won't say their name, but they will literally, every time they come in, they will lie like you can't believe. And, I mean, it's so blatant, but sometimes it's not. Sometimes it can be very subtle, and you just have to, get that acuity in your mind, listen to these details, and all of a sudden what hits you, and you're like, well, that doesn't sound right. And it's okay to approach people. You don't have to be a jerk about it, but you can approach people and be like, well, you said this, can you expand about that anymore? Or you said this, and it's contradictory to this. So, It just takes time. And I mean, I've only been doing it for a few years, so I mean, I've got plenty of time to be learning this too. But anything online? Oh, okay. Dr. Space, there are standardized measures for malingering too, like the SRS. Or the SIRS, he's saying SIRS, yes he is. Okay. Okay. Did you have any other questions?
Yeah, I'm reading through them right now.
Okay.
Any questions online? Feel free to either use the chat function or we can unmute your line. Happy to have you join us virtually as well.
Whew.
Okay, I have another one.
Okay.
How do you keep your composure when you hear all these extreme, intense?
There's two things, okay. These stories are intense, you know, and we're all professionals here, so I don't have a problem, you know, not being overly detailed or gruesome, but the fact is you're going to hear stories about how somebody was raped several times when they were kids, and it's hard. I specialize in PTSD. I love PTSD. I love working with it, but that doesn't mean I don't take the stuff home tonight. It doesn't mean that when some kid who's 6-year-old says that so-and-so did this to me, you know, I mean, there's a natural feeling to just be like, oh my God, like, I can't believe that happened. It takes time. It's not something you're going to get right away. And I guarantee you, if you do emergency mental work or even in therapy, because some people will drop a bomb on you and then you'll just be like, holy crap, like, what do I do? Are you in internship right now? Or?
No, I'm a first year.
Okay, what program?
Counseling.
Counseling, okay, well done. When you get the internship, you know, you're going to run into it. There's, you guys know what Tumblr is? Okay, Tumblr is this website, okay, and they have like all these GIFs, like the animated pictures and stuff. There's a great one, it's called When in Social Work. It's literally one word, I'll look it up someday. But basically it says, like, it talks about the first time somebody tells you they're suicidal, and it's got a guy running around, like, holding his head, like, oh my God, I can't handle this. And then the bottom picture is, yeah, it says, you know, after the 20th time you've heard it, you know, and it's got a guy just going, wow, just like that. And I mean, I know it's funny, but that's exactly the point. You get used to this sort of thing. When you go into internship and somebody tells you want to kill themselves their first, or they want to kill themselves the first time, it's hard. It's hard to take. When somebody is sitting in your hospital bed and they say, I was raped 7 times in a row by my grandfather, it's hard. You just have to go in there with a blankest slate you can possibly take and just be present with yourself. You know, we talk about that a lot in therapy. Be with yourself and be genuine. If you know full well that a job, you know, like, you know, crisis isn't for you or that you can't handle it, then, you know, look to something else. But be genuine with yourself. You know, if you have, you know, these feelings, explore them, you know that they're there. But as far as keeping your composure, it's just all about being present and paying attention to them and, you know, living through their story. On the other hand, sometimes people will say something very, very funny to you when they're in the midst of psychosis. And again, this isn't to stigmatize or make fun of somebody that's in psychosis, but there are some people that have said some things to me that I almost had to excuse myself because I'm like, holy cow. But yeah, you know, it happens. You know, these things are, you know, these things weigh down on me a lot. But oh, if we have one more, maybe we can entertain one last question.
Any questions online before we thank Daniel? And this is your chance.
Dr. Space, I'm coming for you, sir. Okay.
All right.
Well, I'll offer you. Do you have any last question? Otherwise, like a short one, and then we can wrap up. Anything?
Okay, what made you want to be a crisis clinician?
I don't want to do this forever.
$1 million question.
I do not want to do this forever. This is not a job you do for the rest of your life.
Ah.
I love crisis work. It is so intense, and I guess that's kind of where, you know, I was talking about the narcissistic slide where I talked about myself. Everything I've done has always been emergency. I worked with a horse vet, and we, you know, responded to emergencies. I was in an ambulance, and that's nothing but emergencies. Well, not always, but, you know, that's emergencies. You know, I worked in the Air Force, and while I can't tell you much about it, it was an emergency response team. And now I do this. It's just who I am. I like intense situations. I don't like sitting down. I like to just be constantly big on the go. I work overnight on my shift with nobody else, so when there's 6 people, they're all mine. I don't get to share it with anybody else. It's just who I am. I'm sure there's going to come one day where I'm going to collapse and be like, oh my God, I can't do this anymore. But until then, you know, it's just who I am. So.
Is there anything about the process of finding this type of work that would be helpful for somebody who is looking to work in this field?
Okay. Well, what you generally want to look up, and there's search terms, and you can look up on like professional sites like Monster, and the other one's escaping me right now because there's a really good one. And you can look through other people, but For starters, crisis positions are always in demand because I cannot tell you what the turnover in crisis is a lot. This is a hard job. You will have days where you will sit there and not see a single client all day, and you can literally see yourself with a martini just sitting there going like, all right, I just got paid to do nothing. But then there's other days where you see 6 people in 8 hours, and you finally take a breath, and you're like, holy crap. But to look for these things, you can look for certain terms like crisis, that's the big one, crisis clinician, crisis therapy, sometimes I've kind of seen that one used, admission specialist, but then if you do that, sometimes you have to weed out because they'll have like nurse jobs in there. So, and then if you just straight look for counseling, but more importantly, if you go to like the county, because this is usually a county-wide position, if you go to the county like Champaign County and look up and maybe even call them and say like, hey, I'm interested in doing like crisis work, they might be able to, throw you towards like, hey, this is our contractor, like Community Elements, that's the contractor for Champaign County. And, there's another one for Iroquois and Fulton County. So, yeah.
And you're receiving supervision on site, or do you do that?
Yes. If you are an LPC, your hours count. So right now I am on my way towards getting an LCPC, so that's kind of where I'm going. If Monica, my boss, is listening, no, I am not leaving. I still have a year and about 3 months left until I can get my licensure. So yes, everything you do in crisis work will count for your licensure, as long as you're being mentored and supervised by an LCPC, PsyD, or LCSW, I think. As long as you have something like that above you and you have your group supervision every week, you'll get your hours. So, but if there's nothing else, it is actually about a minute or two over. I thank you all for being here.
Thank you very much.
The link will be on here, so have a good day.
Thank you so much. We really appreciate your time and energy and returning to campus. And for those of you online, thank you for joining us. We will get the materials uploaded to the website in the next couple weeks here. Thanks, everyone.
I have another question.